Documenting time on E&M visits. It's going to go quick, so be ready to take notes. Doctors get confused and they need help when it comes to what needed to be documented on the E&M regarding the review of systems, HPI, past family social history, time, etc. So we need to make this and help them and make it simple for them to understand. Why is time important? Let's talk about documenting time. E&M SLIDERULE. This is a tool that I developed almost 15, 16 years ago in conjunction with the University of Nebraska, and we've created this right here and sold I don't know how many of these. But one of the things I'm showing this for is because in the E&M SLIDERULE, it shows the actual times that you'll find in the CPT code book, on the Medicare carrier manuals, etc. The 40 minutes for the level 5 for established patients, 25 level 4, 15, etc. And then the new times for the times for the new patients are going to be different. And I'll be referring back to these times a little bit later. But if you have one of my slide rules, that's why the times are shown down here. And they vary based upon whether or not we're talking about emergency room visits, consultations, office visits, ER visits, hospital admits, etc. The times are going to vary. And I have all of those on this particular slide rule right here based on, however you use it. Okay, with that said, let's move on. What times are we talking about? There's a difference with Medicare and CPT coding, and there's a difference in the term of nearest and threshold. Medicare uses threshold time, meaning that you must have at least that many minutes. If it requires 25 minutes, then if you do a 23 or 24, you cannot use that time with Medicare. It must be a minimum. CPT, commercial, says the nearest amount of time right there. So we need to make sure we follow the difference between the two right here. Now, the 4 instances when time must be documented, if you're going to bill out an E&M code, is counseling. And we're going to go into detail on each one of these. If you're billing out for prolonged service codes, if you're billing out for hospital visit codes, if you're billing out for critical care codes, you must have the time shown. Now, if more than half of the visit was spent face-to-face with the provider, was spent in counseling and or coordination of care, we use time to determine the level of visit. And if the time gives you a higher level of visit than the history exam medical decision making does, then you can go with the time. And so therefore you have a choice between the two. Now when we're talking about the E&M codes and the counseling, I'm giving you some examples right there. The 99211, 5 minutes, 99212, 10 minutes, etc. Those are found on my slide rule and in the CPT code book. What we have to document of that is the total number of minutes and how many minutes was spent counseling and or coordination of care about what. You need to make sure you spell it out for the auditor. Make it so simple that the auditor cannot deny it. So if a doctor is seeing a Medicare patient and has spent 27 minutes and at least 14 minutes of that was spent face-to-face time with the patient, counseling and or coordination of care, coordinating care with another doctor, coordinating care with home health, DME, etc. And this is not nurse's time, this is the doctor's time, or this is an NP's time or the PA's time. Then you can go ahead and just use a 99214. Now let's say you have 31 minutes. 31 minutes on a commercial insurance company would still be 99214 because it's closer to 25. But if you had 34 minutes, well, that's closer to 40 minutes. So for commercial insurance, 34 minutes would give us a 99215. Medicare would still only be a 99214. As I said, this is a mini webinar. I'm going to go quick through this right here. If you want the full 1-hour webinar with the PDFs that comes with it, you can find that on my website. Prolonged service, that's the second time we're going to talk about right here. Prolonged service is the doctor spent longer with the patient for some medically necessary reason and has documented that and has documented the time because this is above and beyond normal time. Let's say a patient comes in here, a normal 15-minute visit would be, say, a diabetic follow-up, 99213. Using the history exam and medical decision-making might be a 99213. But let's say this patient's also got some kind of dementia and cannot tell the doctor what their blood sugar's been running at home, whether or not they've been getting lightheaded or dizzy, what their diet's been, etc. And so the doctor ends up spending additional time talking to the patient's family, talking to the patient's caregiver, maybe the person who drove them in, and asking questions. Maybe the doctor picks up the phone and calls the home health agency and asks them questions. So now then the doctor spent 45 minutes. Well, the 15 minutes for the 99213 plus the 30 minutes gives us a 99354 billable in addition to the 99213. So we get to bill both of those right there out. Now, the nice thing about, well, one thing to keep in mind about prolonged service codes is you have to document what was it that made this service prolonged. What was medically necessary? Using claims processing manual, transmittal 1490 from Medicare, they come out and say this is time the physician or qualified nurse practitioner personally furnished a direct face-to-face time. As well as that, they require the start and end times. In fact, this is the only time that I know of for primary care doctors that they would be required to document start and end times. The other times, like counseling, hospital, discharge, and critical care services, only have to be the total amount of time duration. Start and stop time is required for the prolonged service codes. Hospital discharge, that's the third time whenever you have to, third instance when you have to document time. Only if you're billing out a 99239. If you're billing a 99238, you don't have to have time shown because the carrier is going to automatically assume if they audit you that it was less than 30 minutes since your doctor did not document time. If, though, the doctor is going to bill out 99239, then you better make sure you document the total amount of time spent, 34 minutes spent, and go into detail. What was you spending the time about? Visiting with a patient, going over results with other caregivers, preparing the discharge record, dictating the hospital discharge record, writing prescriptions, etc. If you spend at least 30 minutes with that, or 31 minutes, that's a more than, so it's at least 31 minutes, you bill at 99239. You're going to find the reimbursements probably about, I'd say typically $25 to $44 additional over the 99238. So it can definitely add up. On critical care, you have two critical care codes. Both of these codes, 99291 and 99292, must have time documented. That's vital. Now, if we're talking about a patient being critical, this does not mean that every time the doctor goes to the ER, goes to the ICU and sees a patient that they get to bill critical care. They must be treating the critical condition. This can be handled in any place of service. A doctor can be doing critical care in the office. They can be doing it at the Walmart and the nursing home, wherever. But just because you go to the ICU does not necessarily mean it's critical care. Maybe you're the primary care doctor going there to treat the patient for a leg wound, but the pulmonologist is taking care of the pulmonary condition that has a patient in critical condition. In that case, you wouldn't be able to critical care, but the pulmonologist would. We have a 91-year-old patient that comes to your reception area. They're sitting there in the reception area, and they reach over and pick up the February edition of the Sports Illustrated, and they see a gal that looks like she does here in this magazine, and all of a sudden he stops breathing because Ethel never looked like that in her swimming suit, and boom, he falls on the ground, and next thing you know, you have somebody running out there to, hook up the jumper cables, plug it into the wall, or bring out the defibrillator, and trying to jumpstart the patient right here. Now, maybe you work on this right here for about 15 minutes. ER techs, emergency medical technicians show up because someone called 911. They get the patient all stabilized. They start to bail the patient back out to the ambulance, and the office manager walks over and taps the doctor on the shoulder and says, walk outside with them. It's only been 28 minutes. I need 30 minutes in order to bill critical care. Critical care pays a whole lot more, so make sure you walk outside with them so we get that full 30 minutes. That's pretty much the four instances when you have to be documenting the time and how you do it. Now, this has been a very quick webinar. I'm trying to keep all these down to around 10 minutes or so. I have a full E&M coding webinar of how to document what has to be documented, etc., including the times, on my website at www.donself.com. You can also find the slide rules I was talking about. We've sold about 7,000 of these right here so far. In fact, everyone in the VA now uses my slide rules because we sold a couple of thousand of those to the VA a couple years ago. You can also get my books, slide rules, or just basically hundreds of free forms and documents on my website at donself.com. If you have additional questions, you're welcome to call us or email crystal@donself.com, my assistant, also my daughter-in-law, or myself, or just visit our website. Let us know what you think about these free mini webinars we're doing. Thank you very much, and have a wonderful day.